Hello, everyone. My name is Mark Mynhier, and I'm a partner within PwC strategy practice. And Vishwesh, thanks again for having us here and for spending some time with you all today. I don't know if I should start my talk given Zubin's experience or if I should just tell you a few jokes because I need the slideware. Okay. One of the things that I think was extremely clear about Zubin's introduction is that we're here. All of this new technology, all of this new information, it's here, it's around us, it's being collected, whether we like it or not sometimes. And I think in the context that he was giving, some of those charming images, some of the connectivity that you can imagine, the expanse that makes life maybe a little smaller sometimes, those are all very real and very effective. But what I thought I'd do with you today, with 3 simple slides, is to just describe how this is going to impact us within healthcare. And in particular, I really just want to bring up 3 cases, 3 examples. And within our firm, we really do rely on the experience and the engagements that we undergo to guide our future. So what do we mean? We came up with this notion. It's probably not worth saying it's ours alone, but the notion of a new health economy was something we thought about 5 years ago. And the reason that that was so important is because we needed to stand back and appreciate what were the forces that were going to impact healthcare today. And we were asking this question 5 years ago. And what it informed us about was that we needed to acknowledge the existing players within healthcare, the existing health providers, the new entrants, the new funds flow, the new technologies, the cognitive, soon-to-be AI-enabled technologies. All of those things needed to come together. And for us, over the last 5 years, we've made a few bets, and we've had a few experiences that maybe give you a little insight into what it means for us to be in this new health economy. And the operative question we are responding to is, why do we need to share data in this healthcare context? Why is that the right thing to do? How do we get over some of our barriers and predispositions about that? So we're listing in here 3. The first one we write, and it's an engagement we ran with an academic medical center, and that focused on cancer. And we describe it as minimizing care variability. Well, this is an extraordinary proposition within the cancer domain, and that's even within the United States, let alone across the world. We found that, and this was also an engagement that involved some new emerging cognitive analytics, and the combination of the 2 required more information than we've really had before, and definitely more information that sat within any one EHR, any one electronic health record. So the proposition for this engagement was, how does an academic medical center, a center of excellence, extend its insights and its capabilities, its superior standards of care to all the network partners that they have in the country? And that was this proposition. And the goal was to minimize the variability of treatment variation at those remote sites. So what we ended up focusing on was, how do we get the information from the entire longitudinal experience of a patient? And that meant pulling from their primary care, that meant pulling from a variety of institutions that they may have visited, that meant pulling labs, that meant pulling a variety of information to justify and reinforce the diagnostic or the diagnosis that was identified, as well as the full character of the profile of that patient, something that we haven't done as richly as you would imagine in the past. So as we started working on this engagement, we realized that the wealth of information needed to be accessed across a multitude of institutions. And that was the first inkling of, we have work to do. We have work to do to go out and collect this information, convince participants to share that patient data in the context of care, and know that we were going to protect it or make it secure and respect the privacy regulations, at least within, all 3 of these happened to occur in the United States. And that was our first foray into realizing we were in a new age of data fluidity that needed to take place in support of patient care, especially if we wanted to do the very best for the patients that we could. So the treatment advisories is another example. When we work in organizations like this cancer center, they have a tremendous amount of experience and insights, and these things can be shared with remote sites that simply don't have the same volume of patients that they see at the academic medical centers. So that means we can imagine prophylactic treatments, we can imagine being sensitive to certain unfavorable trends and then modifying treatment regimens, or looking deeper into whether or not there might be comorbidities that create challenges within any treatment recommendation that they're undergoing. So that was our first example, and it has been an exciting project and one that's bearing fruit. Things take time, but those connections were made, the data was shared, the analytics are able now to digest the breadth of that longitudinal information for the patient, and I think we're seeing some of the early signs that this is part of the future. The next one we have up there is in the research context. When we talk about developing precision therapies, we're working with an academic medical center that has decided to knock down all the barriers between the clinical and the researchers, the clinicians and the researchers. And to that extent, we're bringing data from EHRs, we're bringing data from specific 40, 50 different discrete labs that have a variety of funding. They have constraints with IRBs or institutional review boards or ethics committees. There's all kinds of constraints around these respective data types, but yet the prevailing sentiment is that it's the right thing to do, to bring all of this information together and integrate that to drive deeper insights into how care can be affected, or how we can guide specific research that now incorporates more than the specific data that you can collect in a trial. How can we elaborate on the research data? How can we translate research into clinical outcomes or recommendations more efficiently, more effectively? That's what we were able to do when we broke down the barriers between the clinical data, the genomic data, arguably even some of the social data that would be relevant to guide compliance, for instance, on any given treatment regimen. The third one has to do with consumerization of healthcare, and it's probably the one that is most emotional for us within PwC and our practice in the United States. We're working in a low-income area, and we are acknowledging now that, as Zubin mentioned, the consumer-led healthcare experience is here, even in the lowest socioeconomic bands or socioeconomic strata of the United States. And in this particular case, it was notable that we had expectations for convenience, need for convenience, absolute need for affordability. We needed to acknowledge that all of us have been conditioned to have choices and opportunities to decide where, how, who we receive care from. And it became very real in these remote communities where there is a very low or a poor ratio of patients to primary care and poor options for them with long wait times to be seen for conditions that may well exacerbate and send them into ERs. So the rationale for sharing is abundant. The reality for us that we had to establish was, how do we do this effectively across such a broad region, various use cases like we've just described? What you see in place here, notwithstanding the obvious plug that this is one of our technologies, it's not necessarily true that it's the only technology out there, but we put one in place to facilitate this sharing. And what this accomplishes, as you'll see here, is that it accomplishes the data sourcing and integration from a variety of institutions who are involved in the care of a patient. That's not the easiest thing to accomplish. And I'm going to get along the bottom there. You'll see some of the things that helped us accomplish this. We needed to bring in data from hospitals, from retail centers, from community programs, and from pharmacies, all in the context of trying to get a holistic longitudinal image of a patient and to pass that view of the patient to the next person that cared for that individual. That is an impressive proposition. That's continuity of care, that's cooperation within healthcare, that's collaboration and cooperation across legal entities, and that's just a remark to say there are risks, there are considerations in there about liabilities and who did what in the context of care for that person over time. What you also see is a hosting of a variety of analytics. It was critical. From our point of view, what we thought the world needed at the time was an opportunity to bring a tremendous amount of varied data together, but then also to host in a neutral fashion any number of analytics that ecosystem of participants felt they needed to surface insights or to provide guidance to caregivers, whether you be the doctor, a nurse, a licensed practitioner of some kind, or an unlicensed practitioner down to a community worker or an uncle or auntie, right? That entire spectrum needed to be supported, and that means we needed a spectrum of analytics and tools and mobile devices and such to be available. What we found is that in order to make that happen, you'll see along the bottom, we've had a series of technological advances. You might imagine all of the social, mobile, analytic, cloud technologies, all of those are being employed these days because that's the base. But we also have a lot of important controls and security and privacy considerations that need to be employed as well. And when you're working with such different impedance companies, a small clinic, a mobile clinic, a mobile device at home, or a hospital, for instance, with enterprise EHRs, those are very different constellations of technology and infrastructure that need to work together. And that's where we sat in the middle, and we've built this type of technology, as will others, build these types of technology to make that possible. To facilitate data movement, though, don't kid yourselves, these contracts is what officially made data move. And there were several that were critical. We needed to get a convening contract by somebody who took responsibility. It can be a state entity, it can be an insurer, it can be a self-insured employer, it can be public, private. There are a lot of choices, but somebody does have to take control in this model. Because by taking control, they establish who should be in, and that's important, and it also says what their specific roles should be. So what that translates into, that convening contract, is then the contract that the technologists deploy, like we do in this particular case. It's a data use and sharing agreement, and that is put in place to affect what that convening agreement said. So somebody says what we're all going to do, and then this next agreement says how it's going to be done. And when you agree to these actions, you agree to these controls, you agree to manage the identity of everybody in your organization who's going to use that data for care purposes. All of those rules come out, and so do the liabilities, so do the indemnities, so do the intellectual property considerations. That's real. And nothing's going to move, we've found, and now we know after 3 years of doing this, until you get to agreement on those points. And you know what helps us get to agreements on those points? Who the convener was. We were not the convener, wouldn't have worked. It depends. You have to have some credibility. There needs to be some context as a covered entity or someone who cared about those lives. In one case, we had a state entity. In another case, we had a world-renowned cancer center. In another case, we have a state entity again looking out for an entire population in the southernmost part of the United States. These are the drivers that make the other organizations and participants agree to join in and share data. Share data doesn't happen by putting everything into a pot, flipping a switch, and everybody analyze it, and then suddenly you get answers. It's just not true. What we have agreed to is that we need somebody to care, and then we need somebody to control, and then hopefully we never lose sight of the fact that we need people to deliver the care. That third point around shared services was something that became extremely apparent and aware, and we happen to be very sensitive to the need for operating controls in place. Imagine change management, imagine administrative controls, imagine all that messy stuff that makes things work when you have operations spread across 7 or 8 different entities. Well, somebody has to pay attention when there's in fact a failure of a technology, God forbid a breach, which is a when, not if situation, or if there are certain changes in any one of the participants that doesn't allow them to participate anymore, there are decisions that have to be made. When a new participant needs to come into the ecosystem, decisions have to be made. There's governance here that's meted out by these shared services. So that's an important consideration that many don't realize until you get into running one of these ecosystems. That becomes extremely important. And let me say on the last one, on the value capture, nothing moves unless you maintain, and it's a point I make later. In fact, I'll go to it because I'm sensing I'm going to get a bell here in a minute. Nothing moves unless you maintain the integrity of all the participants. No one wants to join an ecosystem then be made irrelevant. And by the way, there are huge sensitivities. Hospitals, if you're touching their volume, they want to know what you're doing. It was not good volume in the first place. They don't care. Fair point, because we need to know the intended consequences and then be prepared for addressing some of the unintended consequences that arise from this. And that's where we put these lessons learned in here so far. I think it's important to know, and we've said repeatedly, this strong convener, I don't know how to do it without having somebody take charge and have a point of view, and a point of view that aligns with the needs of a consumer. Not just a corporate entity that comes in and talks earnings. That's not what's working. Admittedly, when companies do this in the United States and we support healthcare and have some role, there's a gray area. But what we've learned is that their intention is to create increased productivity, quality of life, and that's the only way that in the US at least, I imagine it's true everywhere, that you have employee retention. And it's very expensive to experience the kind of churn that would come, in fact, now that this is a competitive advantage, providing this type of care and consideration for employees. The next one is the contract estate. We're just clear that that needs to be in place, but facilitating that is no small challenge, but we're getting better and better at it, ensuring that they stay standard. You can't bring in participant 8, participant 9, participant 10, and have them propose modifications to the core contracts. There need to be something in place that everybody can agree to that's informed by that convening agreement. The sustainable economics was something I mentioned to you all. Every person that comes in has to have a viable business model while they're in the ecosystem. So that means, for instance, when the retailers come in, people were wondering, do they want reimbursement? Maybe. In the United States, that's a meaningful way for them to get that. But they also wanted to imagine an improved operation for themselves. So maybe it was just traffic. They can imagine greater traffic into their retail stores, and they think that a bricks and mortar like service, like healthcare, is a reasonable contribution in that community, and also they'll bring traffic into their facilities, and maybe there'll be more purchases. So there's all kinds of business models, ones that we all have to be sensitive to, but that seem to be attended to in these types of ecosystems if constructed well. And then lastly is around the transparency. As I've mentioned earlier, the transparency is for a variety of reasons. Ultimately, there's always someone paying, and that paying individual wants to know these interventions or these new care modalities you're imagining, do they work? How much are they? Tell me the health benefit that you're seeing, and then show me the cost benefit that you're seeing. The reason that that's so critical is at some point the convener is going to say, this one doesn't work, this doesn't work, let's swap that out, let's bring in 5 more, and there's a continuous improvement proposition. But it doesn't come unless we see the transparency across the entire ecosystem that's probably expected on behalf of consumer health. So in the context of sharing, hopefully you have one point of view, well, 3 points of view about how it was necessary, but how we tried to keep the consumer in the middle, and how we tried to do right by everybody who is going to try to deliver care differently, but in a way that really wraps care around the individual no matter where they are, so they can receive it when they need it, where they need it, and how they need it. I can answer questions. I don't know if I can answer questions, but if you have them, or you can talk to me afterwards, I'll be happy to do so. Any question that anyone has at this point? Sure.
Thanks, Mark, for your sharing. So I'm Jamin. I'm coming from IT solutions company, and we provide data consolidation and also data analysis for better reporting for the companies. So I understand that in order for those companies to have like correct results for like healthcare sector, they will need to have a very good data input. So I understand it's an impact and importance for them to get good data and quality data.
Amen.
So this is really one thing that is really crucial.
Yeah.
So, and I understand because there are different like competitors between the healthcare industry. How are you going to ensure that they are willing to share the data? I understand it's something involved with public-private partnership as well, like with health governments, the governments with some regulations. So anything that you can share with us?
Yeah,
Thanks.
Let me see. First of all, thanks for the question. You know, one of the things about data quality, when they come in from a variety of sources, that's no joke. Even the best institutions we work with had 20% of the data that we came in, we had to have cleaned. So there are algorithms in place for data quality engines and that type of scrubbing that's needed, and it's 20% or higher typically. That's just a lot of noise in the system that we need to get cleared. That's something that everybody has to tackle, that's true. And we're dealing with it as well with the types of tools that exist out there and manual interventions and coding that's necessary to clean that out. when it comes with how do we get everybody to participate or join or share the data, the things that I highlighted, Jambi, is that what you said? Yeah, really involved that convener creating a purpose. In our population, this was 30% detected diabetes and an additional 30% undetected. There were studies that revealed that. That's unbelievable amount of burden. So the cause is there. What we needed to do was to get somebody in place to invite a group of contributors or participants, and then you had to overcome the need to agree to these contracts and do the diligence of your technology. So there's no magic formula for how to get everyone to get involved, but here's what some of the care providers thought. If they didn't get involved, they didn't necessarily see themselves being part of the solution, and they were worried about not offering the very latest that was being considered, you know, whether it be mobile solutions or some of the other care interventions that were showing cost savings and health benefit. So it's not like I have a magic answer to that last one, but there's a lot of diligence, there's a lot of clarifying, there's a lot of worry about their volume. There's worry, by the way, for the private clinicians that health is moving to a retail setting. We don't have the answer for that. I think that plays out so everybody rebalances and finds out where their value can be given, you know? But I can follow up with you more if you have further questions there. I'm sure I'm out of time, but thank you very much. Thanks for taking the time to talk.